Thank you. So, Sri Raju, thank you. And Reena, Vinita, other faculty, many people are not here. Sridevi and Adalakshmi should record this, the date. This day is a special day. We will keep coming back to this day when we talk about history of modern palliative care in India. The time from 1985 to 2022. It's my own thought and not saying something very authoritative, but I believe these will be the preliminary days. It's a long time, true, but these will be possibly be called the early days of palliative care. And starting today will be the time of modern palliative care in India. I'll tell you why I say that. The growth in palliative care in this country from 1985, when let me share my screen. Have you enabled that screen sharing? Yes, you have. I wanted to show you a picture. No, I have not brought it up. Sorry, I don't need screen share just yet. Uh, it started with Dr. Lucito D'Souza. The term father of palliative care was brought up. Please later Google Lucito D'Souza and see the real father of palliative care in the country. Dr. Lucito D'Souza, an oncosurgeon from at that time in Tata Memorial Hospital, founded the first palliative care center in the country. That was the Shanti Avedana Sadan. I have made my pilgrimage to that place. They have two others branches in Delhi and Goa also. So from that time, many of us came into that field later. The growth of palliative care has been very, very slow. We used to say at that time in the 1990s that palliative care reaches less than 1% of the needy in the country. After this, how many years? Oh my God, 30 odd years, we'll still say palliative care reaches less than 4% of the needy in this country. That 4% is also a very optimistic percentage. I don't think it reaches 4% of the people. And to those people who do get palliative care, the quality of care is very questionable for the majority. So you are joining this program at that time, which I believe is the steep part of the growth curve. I say that specifically for a multiple reasons. One, uh, from 2019 onwards, undergraduate education includes palliative care. As was mentioned by, I can't remember whether it was Dr. Kannan or Dr. Gunasilan who said that, that marks the new phase of integrating palliative care. Imagine in 1 year, we have now, I'm not sure, it used to be 88,000, maybe close to 1 lakh of medical graduates will be passing out every year. And in 10 years, we have a substantial number of medical graduates uh, as a part of the medical fraternity of the country. If such a substantial number is exposed to palliative care, you can imagine the remarkable change. Secondly, the National Health Policy of 2017 includes palliative care. It is not only in paper. Already, national level trainers in palliative care and state level trainers in palliative care have had their training completed. It will, to a certain extent, depend on the implementation in the states. Nevertheless, The national health policy is designed to reach 50,000 family wellness centers all over the country, and the majority of them having some degree of palliative care awareness. You can imagine how tremendous is the change that we can expect. Which brings in the importance of the day and your presence here. When I'm just mentioning some names that I see in front of me, when Dr. Karthika, Dr. Hariharan, and Dr. Jennifer start teaching palliative care, the positive fallout is going to reach geographically growing number of people, because you are going to transform the attitude, the skills, and the knowledge of so many budding doctors. And the impact will be on every patient whom they will treat. It is for this reason that I say this is a momentous occasion. From 2019, we have been struggling to get this program going. The COVID, oh no, 2018, the pandemic did bring in a lot of havoc and delayed us. Sridevi, kudos to you. You have been like a steamroller, overcoming barriers and getting the program there. Let me make one confession to everybody. We do not know how to go about this business of improving palliative care access in the whole country, or in improving undergraduate medical education in the whole country. We together are going to find out how to do it. It is an experiment in a way. And fortunately, it is not a blind experiment. It is a learned experience, because we have people like Reena guiding us, people like Vineet and many other faculty members who have, like Dr. Lulu Matthews and several others, who have worked very closely with us, because these combined brain power of these people, the combined power of their experience, will give us strength. So please remember that nearly 3 years of efforts have gone into this first experiment. Uh, and most importantly, this course will finish in a few days. Our collaboration, I hope, will not finish then. I hope from that point of time, we will be co-conspirators in this noble conspiracy to improve humanity in healthcare in this country. Raju, we will all depend on you to make sure that we do not lose touch with one another. I know you have done already conducted a more than 105 number of echo courses. But this is the most important. This is a trendsetter. These people who have joined the course are vitally important for the future of our country. They are important for my well-being when my time comes to be a patient. So let us also, while Sridevi is planning out the course and the curriculum, let us also plan a strategy to keep everybody together, to gain from their combined experiences, their feedback, and their directions to show us the way forward. Reena, particularly to you, you don't know how grateful I am to you. Your wisdom has guided the development of this course enormously. So particularly, thank you. I'm going to show a few slides that's not really about this course, but about the reason for the course. The phrase integration of palliative care came up. I haven't got a slide on it, but in 2014, the World Health Assembly the decision-making body of World Health Organization, in their resolution number 67 of 2014, made the recommendation to all member countries to integrate palliative care into healthcare at all levels, primary, secondary, and tertiary, across the continuum of care from the beginning of the suffering around the time of diagnosis to the end. This is the mission that we are together going to try to achieve. And you may be from different kinds of institutions with different kinds of backgrounds. But I believe this image should guide us. You are based somewhere or other. I see so many friends from Puducherry and from other places. In your own place, you will be providing clinical care and you will be demonstrating that. This is important. Almost everybody is already practicing palliative care. How you demonstrate palliative care is going to be understandably vitally important for the rest of the country, because you are going to also not only demonstrate this, also educate medical students with this. You are demonstrating all this and you are educating all this. But I hope you will also accept this role of facilitating further development. If each institution facilitates growth of palliative care in the family wellness centers around them, in your adjoining institutions, and in faraway institutions, together we will reach. You know how many people we have to reach? It is estimated that around 10 million Indians are in serious health-related suffering and need care. The Lancet Commission of 2017 made an estimate of 7 million based only on 20 conditions. Many are left out, and together the number must be about 1 crore of people. As we sit here and talk, 1 crore of people are in serious health-related suffering. That's the task we have to do, and that we hope to achieve by demonstrating quality care and then by educating everyone and by facilitating growth of policies, programs, laws, and facilitating development of palliative care centers. What we are now doing with this course is it's an example in the facilitating palliative care education in the country. I am saying this because sometimes, with the enormity of the task that confronts us right in our institution, we sometimes forget the larger picture. You cannot do everything together. Yes, of course. We took more than a quarter of a century to get where we are. It will take time. But we keep the goal in mind clearly. And as you proceed, when you try to make a change, you are agents of change. You are agents of change. You are changing the way healthcare is given, infusing compassion into it. You are changing the way medical education is happening by including palliative care into it. And when you try to do this, let me warn you, there will be some people who are always ready. That's not a warning. That's a positive thing. Some people like change. It's a minority. Let us do it differently. And Sridevi says, let us. That is ready, ever ready people, ready to take on challenges, ready to change. Unfortunately, you will find a substantial number of people who belong to the never, never category. They resist change. They resist change with fighting. And unfortunately, many of them will be of my age group. We older people find it difficult to change. Please have compassion on us. We may fight, and that's because we are afraid. This girl, Sridevi, is coming and asking us to do things so differently. How will I ever do it? And that fear in us will come out as anger. And each one of you is going to confront this. When you try to do things in a different way, you are going to face resistance from some groups. The mistake will be to concentrate on them. Oh, Bapre, he said that. What will we do? And then you go after that person again, and you get disheartened. Management people teach us to ignore the never people as much as possible. That's not out of disrespect. It is just our own survival. We cannot continuously take on this antagonism. Leave them alone whenever possible. If they are blocking something, find a way around that. We work with the ready people. You will find them. You work with the ready people. And then as you work more and more, you will find that the middle group is gradually shifting towards you. After some time, a few people from here also join you, more and more, so that before you know what has happened, a significant number of people have become ready. Okay, this is not going to happen in a day, true, it will take a few years, but this is sure to happen. I am saying that from the experience of all palliative care professionals over the last quarter of a century in the country. Every pioneer faced stiff resistance. Vinita must have felt that. Reena, I know, has felt that enormously. This is inevitable, but when we are persistent, we increase our numbers. Persistence is the key. Why am I saying this? Because after this course, we are all going to start teaching palliative care in various phases of medical education. And when you do things differently, this resistance will come in. If you keep teaching it, you will want to do it more and more. You do palliative care and again you feel resistance. I will repeat. Please try to ignore and steer away from the never people. Don't waste your energy fighting them. It's not worth it. You don't have to win arguments. Work with the ready and be persistent. Persistence is the key. And that change happens when we model the way. We have to show how we manage to do what we want to do, and things will change. This is the first session. I don't want it to last forever, but I would like some reactions to what I said. I assume that we have a few minutes more. Yes, I have. I have at least 6 minutes more from the time Sridevi has given me.
You can unmute and share your response, or you can type in the chat. We prefer you to unmute and talk so that we can have a conversation. Sir, Dr. Nandakishore, you are about to tell.
Yeah.
Yes, sir.
I completely agree with whatever.
Sorry, I can't hear you.
Can you hear me, sir?
Yes, yes. Dr.
I completely agree with what you
Dr.
mentioned.
Nandakishore, your voice is dropping. I don't know. Sridevi, are you able to hear okay?
Yes, sir.
Okay. Okay, Dr. Nandakishore, I'll try harder.
I'll speak slowly, sir. Can you hear me now, sir?
Yes.
So I completely agree with you, and your enthusiasm is infectious. The point that I thought in this, what we need to focus apart from all other things is that we do talk to students, we do talk to the younger doctors about the importance of palliative care. But it is the learnings that they have is not experiential. It is not that they experience the significance and the role of palliative care in day-to-day medicine. And that is the challenge that we will have to understand. How do we make the principles of palliative care and experiential learning for students?
Dr. Nandakishore, thank you. Very wise words. Yes, if we only talk about compassion and they go to the ward and they see only people being shouted at, the knowledge is dead. It is not alive. Dr. Nandakishore, therefore, we have not only to educate, we also have to demonstrate. However small that is, let us not underestimate the power of one. The power of one is enormous. Dr. Nandakishore, you are there. Sorry, what specialty are you from?
Sir, I'm a surgeon, sir.
Okay, excellent. Okay, when they see a surgeon actually sitting down beside a patient, laying a hand on a hand and saying, you seem to be very worried, the student will learn from you. You have to live palliative care. And everyone here, Dr. Nandakishore is asking this so that all of us can take that lesson. If you do not have a palliative care service there in your institution, this is particularly important. You have to live palliative care. When the patient says, oh, doctor, since the time of operation, I am in agonizing pain. Many people may say that doesn't matter. You will be okay in a few days. But Dr. Nandakumar will sit down there for a second. He is a busy man. He can't sit down for half an hour. But for 1 minute, he sits down and tells the person, okay, I see you are in pain. We will do something about it. We will give you enough pain relief. And you take the trouble to make sure that the patient gets pain relief. That will change the attitude. And these things grow, Dr. Nandakishore. If there is darkness there, you light one lamp. I'm sure there will be many who will come and light their lamps from you. We will make a beginning. So let us take the lesson from Dr. Nandakishore. We will start teaching palliative care in the classroom. But somewhere in the back of your mind, we will remember, I have to live palliative care. And we will develop a palliative care service so that the patients will have experiential learning. Dr. Nandakishore, thank you for that question which brought in a powerful lesson, learning point. Thank you.
Thank you so much, sir. Sir, I think we have just
you have two. I have 2 minutes more.
Yes, sir.
Yes,
yes,
so
sir.
one more question I can take.
Any other question or thoughts? Please unmute and talk. Like Dr. Nandakishore brought in a very important point. So there are a few points that we would like to hear from you.
Hello, I'm Dr. Ragesh. I'm in charge of the palliative medicine in Amala Institute of Medical Science, Thrissur.
Hi,
So,
Dr. Ragesh. Dr. What specialty, Dr. Ragesh?
Palliative medicine.
Okay.
Okay, I'm in charge of the palliative medicine in Amala for last 5 years. So when I'm in our hospital, house surgeons come for regular posting in palliative medicine. So from last 3 years, they are coming regularly for palliative medicine. So they say seeing cases. So what I found difficult in training them is that whether we should teach more about empathizing to the patient, or whether we have to focus on teaching them the medical, that is symptom management, symptom control. Both is important. No, just knowing empathizing the patient doesn't makes it full sense. So you have to teach them symptom control also, how to manage palliative patients, how you can manage symptoms, how to use morphine, how to use other medicines. So how can we collaborate these two things? Just sympathizing alone is not enough. We have to teach them symptom control also. So how can we incorporate both together within a short time period? That's one of my questions.
Thank you. I mean, I think your Ragesh, Dr. Ragesh, your question also has the answer in it. What you are really saying is that empathy without action is empty compassion. It almost is like sympathy. Oh, you are in dreadful pain. Okay, bye bye. That will be terrible. I don't think Dr. Ragesh was asking a question. He was giving us a powerful lesson that we have to demonstrate empathy in action. Okay, really, empathy, compassion is empathy in action. You demonstrate empathy through your action in giving symptom control, in psychological support, and in social support for the patient. Dr. Ragesh, if I take any more time, Sri is going to be very angry. I have already exceeded time for 1 minute. Ladies and gentlemen,
Okay, sir,
thank you for joining us on this exciting journey. I certainly am excited. Thank you once again. Sri, thank you.
Thank you so much, sir. Thank you so much, everyone, for the interaction. We expect more points and interactions like this in the coming four more days. Thank you so much. Without wasting time, I'm handing over to Dr. Reena. Ma'am has already introduced herself. Ma'am has been with us through this journey. With her guidance, only with her guidance, we've reached till this workshop today. Thank you so much, ma'am, for all the support that you have been giving. Over to you, ma'am.
Thank you, Dr. Sridevi. I'm feeling very guilty because I know I have not done enough, but anyway, a little is better than nothing. As Dr. Rajagopal said, this is a historic occasion, and I have put a little link on the for us to touch base with ourselves as to where we are before we venture on this journey, and we hope it'll help us in learning further. The link is right in the chat box. And is my screen visible, Shri?
Yes, ma'am.
Okay. So in my first talk today, I will be using a little bit of medical education technology jargon because we are trying to put this into our institutions. So let me begin with our specific learning objectives. I hope at the end of this half an hour, you'll be able to list a few ways in which palliative care can be integrated in the MBBS curriculum amidst time constraints. You will be able to discuss the rationale for the teaching learning methods chosen, to suggest TLMs applicable in the local context, reflect on reasons for teaching palliative care, and reflect on barriers to teaching palliative care. So it is with that intention that we have this little Google form there. So maybe if you could just take 5 minutes, give your honest, instinctive answers to that form, and then we will proceed.
I hope everyone is able to see the link in the chat. So please fill in the Google form.
Shri, I already filled this yesterday.
Oh, is it? Okay.
Yes, ma'am. We circulated this.
Oh, great. Okay, that's good. So that gives me 5 extra minutes. Thank you.
So those who have not filled in, please, we'll circulate it again after today's session in the WhatsApp group. So please feel free to fill in that.
Right. Okay. So When do I teach palliative care? Where do I find the time? What do I teach? How do I teach? And why do I teach? How do I find the time? We all know career cares, everybody is fighting for it. And some of us may be in small positions in small departments with very little medical student contact. And as Dr. Rajagopal showed us that normal curve, it can be difficult. So prioritization is vital. I thought I would just share my own little experience. And I would say begin where you can. So in the late 1990s, this was actually even before my first palliative care exposure. Dr. Robert Twycross had left a book of Oxford textbook in palliative medicine in our institution. And within that, I found things on cancer pain management. At that time, in the prehistoric era when we didn't have internet and when our cancer textbooks didn't contain anything about the WHO ladder, this was an eye-opening experience to me. So as a junior lecturer in radiotherapy, I was given 2 classes to take with the medical students. They spent a total of 5 afternoons in the department. So one class I used to take common cancers treated with radiotherapy, and the second one was Introduction to Radiotherapy, in which I talked about RT machines and basic RT techniques, which but after reading this bit in this book, I thought maybe let me take away my basic RT techniques and instead talk about the WHO ladder for cancer pain. Would anyone like to put in the chat box as to what was the rationale for that change? Or you can unmute and say, why replace basic RT technique cancer pain in the 2 precious classes that I have with these students? Well, since we're a little short of time,
Yeah, ma'am, there is a response.
yeah, there is a so it is more common. Everybody is exactly. It struck me that most of these students are not going to become radiotherapists, and if they do, they will learn the techniques at that point. But nearly every clinician will see cancer pain, and it just seemed the sensible thing to do. And now, of course, in our medical education curriculum, we have a justification for that, that the goal of the MBBS curriculum is to produce an Indian medical graduate who can function, not just, repeat knowledge, effectively as a doctor of first contact in the community. So the doctor of first contact in the community, that is a skill that they need. Now, coming to the question of how to teach. So, actually, to be honest, in the first couple of years, I took a lecture on the WHO ladder. But if you have to choose, which do you think would be a better teaching method? A case study on how to write a prescription for cancer pain, or a lecture on classification of analgesics and the WHO ladder? Again, yes. So thank you, Dr. Nandakishore. We chose the case study. And again, from our medical education terminology, we can give a reason for that common sense, that in doing that, we are moving up the Miller's pyramid. We are moving from just recall of the steps of the WHO ladder to application. We are transferring a skill, it's at a higher. And also, remember, we were talking about the doctor who can function in the community. Now, again, I had to make a choice. Which level of the WHO ladder should I focus my prescription writing on? Step 1, step 2, or step 3? What would be your answers? We have to introduce all, But if I'm going to make them go through the exercise of writing a prescription, should I go for step 1, non-opioids, step 2, weak opioids and non-opioids, or step 3, strong opioids and non-opioids? Now, again, I thought of where is the gap? Of course, we teach them the entire WHO ladder and the different classes of drugs, but most of us, without fear, are prescribing step 1. Even the, orthopedic surgeon with a patient with backache is prescribing step 1. Step 3 is vital, but most of my medical students may not have access to that for a while. So I thought, let me teach them step 2, and rightly or wrongly, that was the choice I made. So just now someone had raised the question of how do we teach symptom control or empathy. Of course, we do know we teach both. So I gave them a handout which had stepwise questions, and they worked through that as the interactive lecture progressed. So this is the patient. How would you classify these 3 pains? What would you give at step 1? What is the dose for step 2? What would you give to anticipate and treat side effects? So all these fill in the blanks were there in the handout, and they worked through that. In fact, they started by writing a prescription and finding errors in it. We also, in that little booklet, we gave them a takeaway resource, which had examples of the different steps of the ladder. So this is a step 1 prescription, this is a step 2 prescription, this is a step 3 prescription. And now the majority of doctors in CMC, after their internship, working in small hospitals, and my hope was that this little workbook would be there with them, and there was something they could refer to. We also had some common troubleshooting issues. If the pain is not controlled, is it doctor related, patient related, drug related? What if there is constipation? So a takeaway resource also helps a lot. I still remember when I first heard Dr. Rajagopal speak in 98, he had given a 1-page sheet on the steps of breaking bad news. I had never heard of it till then, even though I had been an oncologist for 10 years at that point. So that was another technique. Now, we all know students, and we know that what comes in the exams is what drives learning. Now, those of you who are in mainstream departments, unlike was the case with me, it is easy because in the pseudo exam, in the end of posting, you could put in a question and students know, oh, she will always ask that, and they will study a little bit for that. But if you are going to include as an exam question, which of these assessment techniques do you think, which would you prefer? Each has its advantages and disadvantages, but which would you prefer?
Madam, it depends on which year of the student we are testing.
Very true. That's what. It depends on the level, the time, the number of students, which year, and who is setting the paper.
True.
I mean, if it's the professor of surgery, he could put it in a modified essay question with his cancer colon. One small part of it could be that. But I think, again, when we look at the Miller's pyramid, the thing about correcting the prescription is a good way where people can learn from their mistakes. And it is fairly easy also for the teacher to correct. If you've got 100 students and you're the only faculty, a modified essay question can become difficult. MCQs are easy to do, tend to test recall unless you frame them properly. But having a little bit of an assessment sort of cements or laminates what you have tried to teach. When I came back in 2002 after my palliative care training in Oxford, I was given 6 to 8 hours with the medical students. Now, why did this happen? Without my asking, actually. No? It happened for two reasons. One was when I first came back from Dr. Rajagopal's clinic, I went and met our dean and I said, "Sir, there are so many things there that we should be teaching our medical students." So he was surprised that somebody is so enthusiastic about all this. The second was because the professor of rehabilitation, who had 15 hours, he told the dean, "I will give 6 hours for palliative care." I was very touched by that. And I think if you are in a position where you don't have much time, maybe there is a senior person who may be able to share a bit of time with you within their context. And, when I think that professor of rehabilitation, the blessings of many patients who have got pain relief will bless his own life. But again, we cannot teach the whole of palliative medicine in 6 to 8 hours, and that too they come in one go in their pre-final year. So again, we have to make choices. So I have a column on my left hand and a column on my right hand. So would you choose the left-handed column or the right-handed column? Again, just put it into the chat box. The answers that have come in so far have all said the right hand, the right is right. Again, what is the pedagogic principle behind that choice? Why are we choosing that? I think my thinking was, rather than what fascinates me in my specialty, how can I bring in competencies and skills that can be transferred across specialties and beyond the MBBS course to what the patient needs? And at that point, there was not a lot of ethics and communication teaching happening. There was a little bit about empathy. Now, when we look back at these things, again, within the NMC's MBBS curriculum, we know that the Indian medical graduate is supposed to play several roles. There are 5 roles, and really speaking, our palliative care training is covering these roles: the communicator, the leader, and more importantly, the member of the healthcare team. I would like to think that palliative care is one of the specialties which is more quick to recognize the roles of the non-doctors in the team, a professional who's ethical, a lifelong learner, and then even more wonderfully, even in that main role of the clinician, which the NMC says, we actually have our specialty up there in that sentence, that a clinician who understands and provides preventive, promotive, curative, palliative, holistic care with compassion. If you're trying to justify it to your deans or to your decision makers, all these sentences in the curriculum are there for you now. And I was so happy to hear one of the surgeons say that he wanted to integrate compassion into healthcare. Now, of course, communication skills teaching. There will be a separate session on that. But again, just to very quickly look at what are our options for teaching communication skills. Would you like to just put in a few answers into the chat box? Shall we take a lecture on role plays? Thank you very much. Good role play, bad role play, what is wrong, then how to do it right. Video examples, simulated practice. Should our videos be from India? Should they be what is available from abroad? Role modeling. Rajagopal sir said, probably the most authentic and transformative method is role modeling. I mean, it is, in seeing sir and his volunteer Meena getting down to the grassroots with their patients, that really my own heart was touched. But of course, when you have 100 or 200 students, you cannot have all of them trotting behind you. And so we do need the other techniques to explain the skills. And again, no answer is wrong. I agree, an Indian video would be better than a foreign, because the thing with a foreign video is that the student immediately thinks, oh, that is okay in their culture, but that's not how we do it here. And which is why before we had Indian videos, I would prefer to do the role play rather than play a foreign video. And then, of course, we can involve students in doing role plays as well and give them feedback in between. I'm sure some of it will be covered in the next session on communication skills, but just one point I would like to before that. Yes, the steps of breaking bad news was again one of the handouts we gave the students so that it was something they could keep. When using role plays, I would suggest that avoid asking the students to do the bad role play. Our students are very talented and they come up with very dramatic and funny examples of how things can be done wrong. And the problem is that then the rest of the class remembers that. They know it is wrong, but they have not learned much further. So if I do a demonstration role play, I would do the bad role play, ask them to identify what is bad. Then I would do the good role play. So they see the same person doing the good role play. And then I might ask them, I might ask some of them to demonstrate that. Now, if you're lucky and you have 4-5 faculty to facilitate small groups, that is great. But if you don't, even if you ask a few of the more enthusiastic people to try and demonstrate what they have seen. So one could good role play oneself, or one could use a video, an Indian video, and say, look at what we are seeing there. Now, how would you apply these principles in this case study? Now, none of these are optimal ways of teaching, but remember, we are dealing with very little time and with large numbers of students. Another type of skills which is so crucial but so important are, non-glamorous things like wound care of the bedridden patient. I mean, if I give them a lecture on that, all that will happen is that they will sleep. How can we transmit this in a more useful way? Now, in my second session today, the lecture is built around an example like this. But for now, I would just like to say that remember, our goal is to reach that patient in need, whom the student may see some years from now. So again, we gave them handouts on care of the bedridden. patient. So it could be something that wherever they are could teach the family. Nowadays, of course, with technology being far advanced, a link to a teaching video is useful. So then even the family can watch that video and learn something. Like I said, not optimal, but better than nothing. And some of these resources are there in the package that has been put together for this MBBS FDP. How can we assess these skills, the communication skills? What methods could be used for assessing these skills? Because like we said, assessment drives learning. Many of you are medical educators, so how would you assess the skills? Patient feedback.
Workplace assessment can be done.
Yes.
Multi-source feedback.
Yes. So especially I think in postgraduate training and in mentorship of junior faculty, workplace-based assessment and patient feedback is really the proof of the pudding, what they're actually doing in real life. With MBBS students, we may test it in a more simulated technique, and as you have correctly said, a communication skill OSCE, a patient education OSCE. Those are things which can be built into the end of posting. So at least students know what they should do. Whether they actually do it, like you said, is something that may be tested later in workplace-based assessment. And again, those of you who belong to mainstream departments, you have the flexibility to sneak these things into your assessment. And students today are really smart. Huh? You can ask them to make a little video about communication. And that's quite good fun for everyone to assess. But again, we have to tell them that the video is not going to be judged on how close to Bollywood it is, but how practical and true to real life it is, how it illustrates the principles. So one of my 3 afternoons was on ethics case studies. And again, I was conscious a little bit that maybe at that time, what ethics teaching was happening tended to be on rather complex scenarios. Birth, organ transplants, things which not everybody has to deal with. So we built the ethics case studies on things they would see, and along with the jargon of beneficence and non-maleficence, just use a simple term, benefits and burdens, like a weighing balance. What are the benefits and burdens of expensive treatments and incurable disease? What is the meaning of autonomy and justice and informed consent when a patient is chasing a false hope because he believes he'd be cured, whereas actually he's not? And again, with ethics, I think it's important to encourage self-reflection, because only when they put themselves in the patient's shoes, suddenly the light bulb goes on and you think differently. So again, in the second class that I take today, I'll be trying to demonstrate that a little bit. I'm sorry that this one is so very didactic. And so through these self-reflections, what does a good death mean to them? What is the financial impact of potentially futile treatments? Now, it would be wonderful if all students could have clinical exposure to palliative care, but there are some challenges we have to keep in mind. You have a few vulnerable patients and a large group of students. That is hard on the patient, which is why if each of you in wherever you work, if you can role model that in the way you take a clinic, in the way you see an OPD, that's something that sticks. If you're someone who takes clinics for medical students, then one of your clinics can, instead of it just being on how to feel the enlarged liver, it could be on pain management. It could be on explaining to the patient the serious illness that is causing the enlarged liver. And my principle was that rather than inflict the whole group on a few patients, I offer an elective for a few motivated students to come and spend a day or two in the palliative care clinic. And we'd got permission from the dean for them to get official leave to do. And so they spent a day with us with different members of the team. They got a patient to work up. They wrote about that. They reflected on that. Like, as we all know, and as Sir also said, you get much further by supporting the motivated ones rather than by trying to battle resistance. And if you're fortunate to live in a town which has a good palliative care facility, this again is something that can be offered. Maybe it need not be in a formal, medical kind of a thing. It can be going there to celebrate a festival, telling them you're going there to learn, not to diagnose. But there are non-intrusive ways, even for larger groups, where you could give a flavor of the clinical element, a video recorded interview, a relative's testimony to the class, a cinema that is true to life, stories written from the Indian context. Many of these can really touch the affective domain, which is the third domain, the cognitive, the affective, and the psychomotor. Talking of the cognitive domain, with things like symptom control, we would give them case scenarios so that they had to both diagnose and then, using an open book, try and prescribe. Time is always short, but in the time that you have, what can you add? Just like you have your food, you add a little salt into it, or you have your orange juice, you add a little ginger into it. So how can I sprinkle in a bit of palliative care? Who else is convinced of the need and may give me some time? What resources can I make available as a flipped classroom? That is an advantage in today's century, that unlike the days when I had to find one Oxford textbook of palliative medicine and then take a lecture on that, now resources are so easily available. Students can be wonderful if you ask them to do a seminar, but I think it's important to moderate that so that the take-home message is, true to what the patient needs. And that's why the facilitator needs to think carefully before it is presented to the larger group. So I just, as we draw to an end, most of your experienced teachers, what techniques can you use to make a large group interactive? Most of us won't have the luxury to have, 5 facilitators to do small groups to teach this. You have your class of medical students. How can you, within that large group, what could you do to make it a little more interactive? I'm sure many of you have already used it in your parent subjects. What would you say? Small group discussions, role plays, debates, yes. So role plays, debates, quiz, those are some things we can do. Voting, group discussion, and then present. And a very simple, yes, raise questions. And a very simple way that I have found helpful is think, pair, share. Turn to your neighbor, discuss with each other, and then I might ask one person, okay, what do you think? because sometimes even the classroom is not lending itself to making small groups that can face each other and talk. Um, so another thing which you can tell your administrators is that palliative care is a great petri dish to grow many of the must-know areas of the new competency-based MBBS curriculum, right from the goal to the roles to so many of the core areas of the curriculum. Palliative care is there. And but really, that's not the main reason why we are teaching. I think the main reason why we are teaching is so that more patients will get appropriate palliative care. And in the course of that, we'll be able to blend the art and the science of medicine to begin to address some of the lacunae in the curriculum. And through that, both, both our students and we will grow as human beings who will continue learning from their patients. So that was all I had to say. In summary, think about why are we teaching this? It is, so that the patient gets pain relief. How will we ensure the essentials have been learned? Maybe by making them correct it. What shall we teach and how do we teach and learn? So thank you for your participation and thank you, Sir and Dr. Devi and Raj.
Thank you so much, ma'am, for sharing your journey through teaching palliative care. I hope that might be useful for many of you who are going to or already teaching palliative care in your institutes. Are there any questions to Dr. Reena? If please unmute yourself and ask, or you can type in the chat. Are there any questions? Or maybe we have 10 minutes break now. We'll take the, yes, ma'am, please.
I had one question. Several of you have already been teaching and practicing palliative care. So what is something that you have found this is really helpful? It would be really nice for the rest of us to hear that.
Hello, ma'am.
Yes.
Madinara. What
Yes.
I found is, to be honest, I didn't find it. The students themselves came up with some ideas. Some of them, I think at the MBBS level with their engineering counterparts and friends, they had some idea of palliative care. And some of them had this interest for social work and trying to do something, they have some kind of empathy or something, they need to do something. So they came and asked me how we can help out. You are doing some work in palliative care, how we can help, can you teach us? So in a small group, when we introduce a subject, then it spread to other people. And so they went and requested the community medicine, and then through the community medicine, I got 2 hours to teach palliative care to I think fifth or sixth sem students.
That's wonderful. It's such a heartening thing to
So
hear.
because as your sir was telling initially, our we are not still in the curriculum thing, so we could not directly go and ask for palliative care teaching or palliative medicine teaching, but it came through the community medicine. Now I am doing 2 hour sessions for one of that semester students every year. So it came through via students via community medicine. It came like that.
That is really. Thank you for that. And that's why that thing about an extra opportunity for the motivated ones can be very, very worthwhile. You never know where it will take you. Huh?
Dr. Chitra, you just started teaching communication skills to medical students, right? Would you like to share your experience? What helped you?
Hello. Yeah,
Yes, ma'am.
you asked me. Yeah, okay. We use your videos. Let's see. Check on it. We use
Yeah.
videos and are able to use it in the ATCOM module.
Ma'am, there are two devices, I think, nearby. So if there is someone sitting near you,
Because
tell
my
them to,
sound is
yeah.
not clear. One minute.
There are two devices in your name. That's why there is an echo.
Yeah, because
No, ma'am. Is it possible to type it in the chat so that we can just read it?
yeah, I will do that.
Anyone else would like to share or comment on what Dr. Reena was talking?
This is Dr. Anand here.
Yes,
Actually,
sir.
the thing is, MBBS students, they don't learn much about communication previously before the CBME curriculum was implemented. But the same thing when we talk about the nursing students as well as the paramedical students who are in our institute, they have separate chapters. Like, for paramedical, they've got soft skills which is present already in their curriculum. So, like, these soft skills have to be taught to the MBBS students as well. So most of them, I think, like it comes through palliative medicine. So these soft skills, when we teach them through EdCom, because EdCom modules which have been recently introduced. So because of that, we actually use these communication skills what we learned in the palliative medicine, foundations of palliative medicine. So we use that video to educate the students, and that was followed by a role play and similar, small gestures which are very important for patient care. That was given to the students, and based on those gestures, the students enacted the role play, and that is how we, are trying to integrate those soft skills to the students, MBBS students as well. Thank you.
Yes, thank you for that important point. I mean, ATCOM is now that very flexible golden opportunity where these things can be integrated, and it is compulsory as well. Huh? Yeah. Yes, thank you, Dr. Chitra. Videos reinforced by role plays.
Thank you so much, Dr. Chitra. And to others who have shared your, we expect more interaction from you all because it's kind of mutual learning also for us. Like there might be new techniques that you will be using in your institute, so it will be good to hear about it. We'll take a short break, and before we move on to the next session, we'll be still here. We are not disconnecting the meeting. So you can all just stretch yourself, get a cup of coffee for 2 more sessions for the day. Thank you so much, Reena. We'll see you again for the next session towards the end of today's program.
Thank you. Thank you.
By 3:40, if you are you don't need to log out if that is okay, but you can just switch off your video, stretch your legs and come back by 3:40. I hope everyone is back. Can everyone just put hi in the chat so that we'll know that you are all back from the break?
Hi.
Hi, Dr. Dinesh. Yeah, everyone is here. Thank you so much, everyone, for being with us because it's a long session. So next, we'll listen to Dr. Dinesh. Dr. Dinesh is the Professor of Community Medicine in Pramukh Swami Medical College, Karamsad, Gujarat. Dr. Dinesh was a part of this whole program since 2019, going through the CBME documents and understanding where it actually comes, which year, how many hours are involved. So all those there are so many experts involved in that, but he was there with us since the beginning of the whole program. Thank you, Dr. Dinesh, for this wonderful journey, and over to you.
Thank you, Dr. Sridevi. So first of all, let me congratulate every one of you that you have chosen that you will contribute to this mission where we'll try to get palliative care into the mainstream of medical education. Okay. The very fact that you are there in this workshop means you all believe this is a very important thing which is probably missing. So the session for today is basically which I'll be talking to you about is the trajectory of illness. So just give me a couple of minutes. Can I share the screen from here?
Yes, yes.
Okay. Yes, is slideshow visible now?
Not yet. It's has started sharing screen, but presentation is not visible yet.
Just a minute. Now?
Yes, yes, it is.
Okay. So we'll begin with this session where we'll talk about the trajectories of illness. So one of the objectives, and what about my audio? How is it?
Very clear.
Reasonable quality?
Yes, yes, it's good.
The main purpose why we want to talk about these trajectories of illness is to send across a message that even though there are many diseases which we know and which our potential students they will be treating, finally if you look from the management point of view, especially towards the end, they will all converge to some common pathways. Okay, so this is the key message that we need to emphasize, that irrespective of the final specialty in which the student is going to specialize, each one of them will have some role to play in the this palliative care, and in their own specialty they will be able to integrate this palliative care. So that is the broad thing that we want to emphasize. So already I need not talk to you about palliative care because Dr. Rajagopal and Dr. Reena would have talked to you about the definition. So, but grossly, if you see what we are talking is, we are talking about improving the quality of life for family as well as the patient. And what I would like to emphasize here is what is not there in the definition. We are not talking about any specific disease. So none of the definitions, whether you take the WHO definition or you take the Indian Association of Palliative Care definition, none of these definitions, they talk about any specific disease. Okay. Uniform kind of palliative care which is required in different settings. So there are certain differentiations that we can make based on the trajectory which most of the diseases follow. Okay. So that is why it's important for us to know this concept of trajectory of disease or trajectory of illness. So this is the famous proverbial story which most of us know. We would have discussed in different settings. Okay. So usually where do we use this story? Any of the participants? Okay. Usually this elephant story and blind man story. So what do we try to emphasize using this story? Anyone from the participants? Okay, they have put it in the chat box. Okay. Just a minute. Let me open the chat
Yes,
box.
it's written perceptions of different views.
So I opened the chat box. Perceptions, different views. Dr. Adinaran has mentioned. Dr. Chitra has mentioned. Perceptions of different people. Okay. So basically when there are several things or several aspects of the one common issue, we try to use it. So here the intention is to again re-emphasize that even though palliative care is the main point that we are talking about, for different diseases, a different set of diseases which followed a similar kind of trajectory, we'll be having palliative care being presented to the patient and family in slightly different ways. So already we know that palliative care, if when we are providing the palliative care, what we are talking about is the total care. And of course, it can have several domains, but grossly, we are talking of providing care in 4 domains, whether it is physical, social, spiritual, or psychological. We are also aware by this time, because none of us is trained to provide optimum care in all the domains, we will require a team, multidisciplinary team, which will provide this kind of care. Okay. So these could be some of the members of the team who will be there. So maybe as a doctor, sometimes you might be leading the team, or maybe you might be one of the team members. It doesn't matter. So, but by our own experience so far, we also know all the diseases do not require same kind of input in all the 4 domains. So there are certain diseases, a certain set of diseases, and during their course also, which keeps on changing, these needs will change. So we'll have to provide this varying combination of palliative care in different domains. Maybe at one stage, physical will take the upper hand, the others might not be the priority at that time, and gradually the priority between these domains will keep on changing. Also, for different disease conditions also, the proportion of resources allotted or the time allotted for these different domains of care will also needs to be changed. Okay. So in addition to various other circumstances which will decide, one important thing which decides what will be the combination of the care that we provide is something known as the trajectory of illness. So before we proceed further, we'll see a small clip, and once the clip is over, we'll discuss the trajectories in certain more detail, and of course some modifications of the trajectories. So before we see the clip, does anyone in the participant group have some idea about different trajectories which are there, which they might have heard or they might have come across? Because when I saw the list, I came to know that several of you are already trained in some aspects of palliative. And of course, I know some people who have been my teachers in palliative care who are there in this group also. So is anyone aware about any model or any set of trajectories of illnesses that people have defined, and they have tried to correlate it to the palliative care needs of the individuals? So you can put that in the chat box if you are aware, and if yes, you can name some of the trajectories if you are aware.
Dr. Dinesh?
Yeah.
Yeah, like for, I don't know what you're talking, but is it like for cancer, for
Yes,
dementia, for heart failure, like that? A short decline or a long decline with a series of ups and downs?
Yes, sir, exactly.
Or there some sudden trauma and death, there is sudden death happening. Those are some of the trajectories which I might be aware of.
Yes. So is that Dr. Adinarayan? Yeah, sir, that is the trajectory I was talking about.
There is a chart also, frailty.
Yeah, frailty, sentinel event, in and out of hospital. Okay, then there's decline, there's some reprieve, then decline, death. Yeah. Okay, so these things which you have mentioned, which Dr. Karthika has mentioned. So in different diseases, the combination will vary. And usually over what duration it happens, so it varies. Okay. So before we proceed with the discussion, we'll have a quick look at this video. This video is prepared by a group which works for primary palliative care. So the group was led by Dr. Scott Moore. So that group has prepared this video. It's available on YouTube for free viewing. You can do that. Right now, I will share the video. Okay, I assume the video is available in, like it is seen in full screen to everyone.
Yes, sir.
Okay, so I'll play the video.
Sure, sir.
Are you able to hear also?
No, sir, we are not able to hear it.
Now?
Early palliative care,
Yes, sir.
different for people
Okay.
with different conditions. So this talks about the rationale for early palliative care. It's that there are 3 typical illness trajectories, each with 4 dimensions towards the end of life. Early palliative care may prolong as well as improve life's quality by promoting realistic medicine, and many people.
Yes, we can.
Okay. So before we proceed, would any of the participants like to summarize the video for everyone? And what is the take-home message from the video for us? See, especially when we will be dealing with the students and we have to share similar sessions. So we use videos as a quite powerful tool to send across the message and also to reinforce certain things. But for this to work, it is very important that each video is followed by some debriefing sessions. So either it could be done by the faculty, like you could directly debrief, or you can get the participants to debrief it for you. And then if there is something needed to be added, we can do it. So here we'll ask the participants to speak about this video. Any of the participants would like to summarize the video?
Dr. Karthika has mentioned in the chat.
Yeah, okay. What is it? What has she mentioned?
The plan of palliative care is different for different types of trajectories of illness.
Okay. So, okay. So that is the take-home message. But does everyone out here agree that they are this kind of trajectories, maybe based on our own experience of different diseases that we have seen? So do we agree with the kind of trajectories which were shared in that particular video?
There is another chat, plan for early intervention for rapid cancer trajectory.
Yeah. So see, again, these are some, I would say, some things which have been summarized for us. Of course, when you are dealing with the individual, the trajectory might not exactly follow this thing. So based on that, you can take a call. But it is, as it has been advised, it is a very wise thing to be aware of this concept. And this could be used very easily to educate the patient and families. So the simple curves which you can draw on piece of paper and kind of explain to them what we expect over the duration. So it gives them a very good idea of what is to be expected. And of course, we can plan our care around that particular curve. Okay. So these are the classical 3 trajectories which were described by that group. But subsequently, people have identified that these three trajectories, they do not meet the entire spectrum of palliative care which is needed. So they've added two more trajectories. Totally right now we are dealing with 5 trajectories. Okay, so we'll see those and these three, how it matches. So one thing which is now coming up and many of you might be aware is this kind of thing where there is sudden death. That is palliative care in emergency setting. So there's a group of people who believe that even when lifespan is very, very short, maybe few minutes, or maybe even when say the patient has expired in an emergency room setting where he did not have time to build rapport with the patient, but family is still there. Okay? So something can be done for their needs also. So that is altogether a different thing which is there. Palliative care in emergency setting or palliative care in ER setting. So that is one thing. So which was not mentioned in the video. So that is first thing. Another thing which has been mentioned is a event which has got some catastrophic event, but death doesn't follow immediately. Okay, so the classical example we can think of is stroke or COVID, where the function status goes down tremendously, and then it is almost at very low level for very, very prolonged time. So you classically can think of someone with stroke, or maybe someone who had COVID and is now suffering from post-COVID sequelae. Okay, so their function status goes down very, very fast, almost at the speed in which you see in the sudden death rate, but there is no death. Death is delayed to quite a long period. So that is another trajectory where the needs are slightly different from the way it is defined for the classical 3 trajectories. Then of course the 3 trajectories we already discussed: the rapid fall cancer trajectory, the gradual fall of advanced organ failures, and the frailty trajectories. So these are the now 5 trajectories which are kind of used to describe the path which different diseases take, and we have to use these to titrate the palliative care needs of the patients, because for each of these trajectories, the combination in which we provide the needs will be slightly different. It goes without saying that all the 4 domains continue to be important for all the patients, but the timing of interventions for each of the domain, the amount of intervention that you provide in each of domains, it will vary depending upon different trajectories that you are dealing with. Okay. So now, does any of the participants have any query about these 5 trajectories as of now? Or would you like to comment anything on this at this stage? Because this will be followed by a small exercise that we'll do.
There is a question in the...
Okay, what is it? I can't see the question in the chat.
No, sorry. That was an earlier chat.
Okay. So you all agree that this could be the starting framework for the exercises that we subsequently want to do in the next couple of minutes. So again, once we share this with our students, when we are implementing the inclusion of palliative care in the curriculum, so after this, it is useful that we try to give them some examples of the trajectories which are there and ask them to identify the needs which could be there for each of these. Okay. So as I told, the sudden death scenario we are not discussing, because that is, I think, altogether slightly different aspect of palliative care, which not widely practiced, and of course we don't have expertise in that also. So we'll discuss these other four scenarios: the catastrophic event scenario, the cancer scenario, advanced organ failure, and the dementia or frailty scenario. Okay. So these four we can discuss with the examples. Okay, so there's something in chat. What is it? Let me see. No, it is not prefixed. It is based on the disease trajectory which is there and based on the natural history of the disease. Okay. So maybe in cancers also there are certain cancers which might not follow this classical trajectory which is described here. Okay. So it is based on the, it's not prefixed, it is based on the natural history of the disease and how this particular individual is responding in the particular disease. So based on that, you will decide the trajectory. So, okay. Hope I have cleared that. So, yeah, this is the fifth trajectory we have discussed. Because this is relatively new. So it was described basically, it was there earlier also, but with this COVID thing, this came into more limelight. Okay? And people had this sudden event in large scale, and there were lots of this post-COVID sequelae which were happening. So that is when it came into picture. So it is basically sudden death with frailty. Both things are there. So accordingly, our the interventions will be there. So basically what you will be dealing with the sudden state of frailty and dependence. But the duration is very, very long. So this is about the fifth trajectory. Now for us to know, other important thing is what is the distribution of diseases which follow these trajectories in our country. Of course, you can, it will be advised if you can pull out similar data for the state, or if you're even at the district level, that will be great, but at least state level, you'll find some of this data, and that you can use it to emphasize upon the students that these diseases are found in this kind of proportion in the community, and you are likely to find out, you are likely to see patients with this kind of trajectory in this proportion. So if you look at the country level data, so this is the data which was there in 2015, MCCD class data. So where we try to find out what are the different important causes of death in the country. So if you right now, if you see, the commonest cause of death in the country is cardiovascular, which contributes to around 29%. Apologies for this jumbled up legend. I'll send across the clearer slide, which can be seen by you. So right now I'll read it for you. So you can find out similar data, which for maybe for your state and maybe for your own hospital also. And that data we can correlate with the trajectories. These are the 5 trajectories, and these are the set of diseases which are likely to follow this trajectory. And this is the distribution that we see in the community which we are going to deal with. So it kind of gives the students some perspective about what they are likely to face when they enter their clinical practice, and what are the, of course, we'll emphasize more on the different palliative care needs which might be there. Okay. So the single most common cause is cardiovascular disease, around 29-30%. This 13.8 is the infections. Okay. This 6.6 is respiratory diseases. This blue 7.5 is the malignancy. Okay. So these are the important things. So this malignancy is likely to follow the the cancer trajectory. These are likely to follow the organ failure kind of trajectory. Okay. So this is how we can help the students to correlate this particular thing. So the magnitude versus different diseases which follow the trajectories. So next 10-15 minutes, what we'll do is we'll try to, I'll give you a case scenario. So you quickly, this is individual exercise, of course, as of now. So you can write down on a piece of paper somewhere that these are the four domains which you are dealing. I'll present the case to you. So you identify which is the trajectory that we are dealing with. So you can just write like cancer like trajectory, advanced disease trajectory, frailty trajectory. You can mention it. And what are the key issues which are listed in the case, which will go into each of these domain. And also for immediate intervention, how would you like to prioritize this? So that is a small exercise that we can do. Of course, with students, you might again find they might not have the adequate expertise to come to a conclusion to prioritize, but doesn't matter. At least they'll get an idea that is everything is not about the physical. Other domains also, they tend to take priority. So even if you are able to send across that message, I think the purpose of having this particular session would be served. Okay. So I request the participants to just write down somewhere these four domains and be ready. So I'll share cases with you. Dr. Sridevi, how are we placed time-wise now?
We're supposed to end the session by 4:20 because Dr. Reena is taking another session from 4:20.
Okay. So then what I will do is we'll have only 2 cases out of 5, only at least 3 classical cases we'll see, and 2 maybe we can skip. Doesn't matter. Okay. So let me present the first case. So this is the first case. So you identify which trajectory this particular case is likely to follow, and what are the needs in 4 different domains: physical, psychological, social, and all. And if you, as a palliative care, if you have to prioritize your intervention, how would you go about? Okay. So you assume that you have seen the patient today itself for the first. So we'll take, say, around 4 minutes for writing this, I think. In case we'll discuss. If you identify the issues, you can write some of the issues in chat box also. Maybe mention the domain and put the issues.
Dr. Dinesh, are you able to see the chart? Dr. Adinaran has commented on it. Pain source unable to move for physical.
So he has put physical. This thing. Yeah, I opened the chat, so I'll read it from here. No issues.
Anyone else would like to comment? Yes, Dr. Adi has comment. Can you read now, Dr. Dinesh?
Yeah. So he has also mentioned about altered body image, dependence upon other, and separation from child as the psychological issues which have been identified. Okay, so Dr. Madhu has identified bed sores and pain as physical issues. There is mention of existential crisis. And Dr. Hariharan has mentioned that we need to have holistic approach. Okay, Dr. Adinaran further mentions there is social isolation, there is financial difficulties, and there is isolation from family members also. So Dr. Kumar mentions that this is a cancer trajectory thing, and pain intervention and wound care would be primary aim as of now. Okay, so Dr. Karthik has brought out a very important point, which intentionally I had left to the end of the discussion. All the domains need to be addressed. Yes. So what I did not bring up during the discussion is, even though the disease, whichever disease it is likely to follow certain trajectory. We might not be there at all the points in the trajectory. So our entry might be at certain time in the trajectory. Okay. So that is also very, very critical. So yeah, Dr. Adinaran has also brought up some the spiritual issue also, where they have a feeling of worthlessness and why they are suffering for this particular condition. So what I was telling was, even though diseases follow the trajectory, we do not follow the patients as per the trajectory. Okay. So if you look at this case of Ms. Sujata, which we are discussing, so if you assume the patient has, if she has come to your clinic today, so today she is quite advanced in the disease trajectory also. So as someone pointed out, we might have to have multiple intervention. But all said, still it is important that we identify key in her journey towards the end, where at what point she has reached and where we are there at this stage, and accordingly we can titrate the needs. And of course, many people have mentioned different needs which are there. So this would have been discussed earlier. Also, if it is discussed, let me repeat it for the benefit of everyone. Of course, we as care providers have got our own priorities. But remember, those are patients, our own priorities, which we want to apply to the patient. They are not the patient's priorities as might be best suited for him or her. Okay. So while we design our intervention based on our best perspective, our best intentions, it is very, very important that we try to overlap this design with what the patient has in mind, and patient family has in mind regarding different domains that care that is needed, and then come to a common consensus kind of thing and develop the goals of care. So this is how we can use this exercise for sensitizing the students, and of course, once they are through also, you can use it for helping them to recapitulate the finding and trying to hit it into their mind that for any patient that they see, these are the gross framework in which they can deal with the patient. So I think we'll end the session here. And of course, as per the participants, before we end, for which year do you think this session should be useful? Suppose if you want to do this trajectory of illness, so which year it might be good enough to introduce? Last question from my side before we wrap. Third year, final year. Okay, final year. So grossly it appears that towards the later part of their training. Okay, final year, third year. Okay, so I'll stop sharing, and meanwhile the next presentation can be loaded. So let me stop sharing. They are putting up next presentation. Shridevi, I have a couple of minutes, 2 minutes just.
Yes,
One or
yes,
two
Dr.
minutes.
Dinesh.
Yeah, you can upload the next presentation meanwhile.
Which
So
one?
what I wanted to say is we did an experiment kind of thing. No, next.
Okay,
Dr. Reena's
speaker. Yeah,
session.
yeah, sure.
So what we did is we did some kind of experiment. We had the same case, similar case, and we shared it with first year, second year, and final year people. Okay, the same case. And these 4 domain we made and some brief introduction and all. What we found surprisingly was the first year they were able to identify lots of non-physical issues compared to the final years who were basically focusing on the physical issues with the pitting edema, non-pitting edema, and all medicalized kind of findings. You can try that for your students also and share with us. So we had same case in the first year, like during foundation last year, and introduction for the palliative care for the final year also, same case. We asked them to identify the issues. This was our finding. Maybe others can also try this and you can share it in the larger group. So our gut feeling is maybe are we making them desensitized to the other issues as they pass through the medical training? So we have to give a thought to that. Thank you.
Thank you, Dr. Dinesh. So we will be sharing all these resource materials. We have already shared through emails. You might have received a folder containing illness trajectories, what all videos can be used, how we can divide the session, a trainer's guide, the PPTs. So whatever resource material you find useful, please feel free to use them. I think without much delay, I think I'll go to the next session. Thank you so much, Dr. Dinesh, for, I mean, you are busy today, but thank you so much for being with us. Dr. Reena, over to you.
Thank you. And I will also just try and share my screen. Is it visible now in slideshow mode?
No,
ma'am. No? Oh, sorry. Is that okay now?
Yes, ma'am. Yes.
Thank you, Dr. Dinesh. And so, in my first talk, I had sort of spoken as a teacher about some principles of teaching learning methodology. Now, this one, I'm going to pretend that we're going to time travel a little bit, and all of pre-final year students back in our youthful days, and we are sitting in a palliative care class. Okay, so this would be sort of like a first class I would take. So, so the first thing I would ask you to do is, now you can imagine yourself at your current age and stage in life. Okay, and you are told you have a terminal cancer. We know palliative care is not just for terminal cancer, but this is to focus the exercise. So you at this stage in your life, you're told you have a few months left to live. What would be your top 3 concerns? Okay. Please take a couple of minutes to think about it and put them in the chat box. I find this is a good question to ask myself as I go through life at different stages, and it keeps changing. Thank you, Dr. Karthika.
Ma'am, there is one chat. Are you able to see the chat?
Yes, thank you. No? Yeah, I'm just waiting for a few more responses. Thank you, Dr. Karthika. Yes. Thank you. Thank you. I mean, it's actually a very nice exercise, and I wish we could spend more time on it. But even from what you have told me, and these are the things that even, many of these things come in what the students say. Like the very first thing and the most common thing was concern about the family, the financial future of the family, time with them, relationships. And then inevitably there's a combination of other things. Here also someone mentioned pain, someone said say sorry, emotional trauma. So these different dimensions come in when we put ourselves in that in the shoes of being in that trajectory. So when I ask the students to reflect on it for themselves as opposed to for a case study, that is, you get these answers. And so we realize that as doctors, we are naturally attracted to fixing the physical domain, and that is often urgent and necessary. And like Dr. Dinesh said now, the final years looked at the physical, whereas the first years came up with more. But as human beings, like all our patients, we have important psycho-spiritual goals as well, particularly when life is short and time is precious. So I tell them that all the patients who are coming to you, they too have these things going on in their minds, and perhaps our medical treatment should help that rather than hinder that. Sometimes I also ask them that if it was a curable condition, maybe your goals may have been different. So sometimes what is appropriate in curative treatment may not be appropriate in incurable disease. Now, like we said, when we think as doctors, there is a risk that we may miss this whole picture. And the founder of modern palliative care, Dame Cicely Saunders, in a way, I think her life history had something to do with her ability to see the bigger picture. So let me tell you a little bit about her. She belonged to a very wealthy family, and she was a student at Oxford University when the Second World War broke out. So at that time, she felt that her country needed a nurse more than it needed a student at Oxford University. So she went and trained as a nurse. By the time she finished, the war was over, and she'd had a bad spine. She needed surgery, and she was told to work as a nurse. So then she trained as a social worker. And as a social worker, she met a refugee from Poland called David Tasma, who had advanced cancer. I think it was colon cancer. Today we have the Ukrainians taking refuge in Poland. At that time, the Polish were taking refuge in England, running away from Hitler. So David Tasma had no family in England, and his only friend was this social worker. And through their conversations, Dame Cicely came to realize this whole unmet need of someone who's dying. The hospitals don't know what to do with them, and there are no supports in the community. So after his death, she started volunteering in some religious homes for the dying, which were run by nuns. And she noticed that in places where pain medicines were given regularly, patients were both comfortable and alert, as opposed to where pain medicines were only given when the pain got unbearable. And with a senior surgeon, I think it was the Dr. Barrett of Barrett's esophagus, but I'm not sure. And he said, I can see completely where you're coming from, but the problem is that when you say this as a social worker or a nurse, the doctors may not listen to you, which is unfortunately true, that many of us, we are not very open to suggestions from other health professionals. So he told her, why don't you go study medicine and learn, do something in this area. So Cicely Saunders was in her 30s when she started medical school. She was 39 when she graduated, so much older than most of you. And then she went back to working in these homes for the dying and came up with this foundational concept of total pain. So this is one of her early publications about total pain. And in that, she is describing what a patient told her. One person gave me more or less the following answer. In response to the question about her pain, she brings out the needs that we're trying to care for. The pain began in my back. Of me is painful. My husband and son were marvelous, but they were at work and would have to stay off and lose their money. I could have cried for pills and injections, although I knew I shouldn't. Everything seemed against me and nobody seemed to understand. But it's so wonderful to begin to feel safe again. So without any further questioning, she had talked about her mental as well as physical distress, of her social problems, and of her spiritual need for security. So perhaps because Cicely Saunders came from this background of so many trainings, she was able to grasp this in a way which sometimes we may lose. And the other reason why she was able to grasp it is because she listened to the story. In fact, she says in response to one question, she told me all these things. And that is the simplest communication skill, the most foundational skill in history taking, whether you're a first clinical year student or whether you are a senior professor. If we listen, we understand. Now, in more recent terms, we have another phrase called serious health-related suffering, which is what I'm asked to talk to you about. And suffering is health-related when it is associated with illness or injury of any kind. Suffering is serious when it cannot be relieved without medical intervention and when it compromises social or emotional functioning. Common sense principles, really, but basically somebody who needs that kind of help. And what is palliative care? There are several definitions, but this I think is short and comprehensive. It is the active. In other words, we don't decide, we don't do away with, we still make a good diagnosis, we still use our clinical sense. Holistic care of individuals across all ages with serious health-related suffering because of serious illness, and especially of those near the end of life. It could also include others, and it aims to improve the quality of life of patients, their families, and their caregivers. So that is a brief definition of palliative care. Now I would like you to look at this figure and tell me that among the 20 conditions here, which are the top 5 causes of SHS? The blue circles are today's data. The red circles are projections to 2060. So as of now, which are the 5 conditions which we think are responsible for the most of serious health-related suffering? So since we're all pretending to be medical students now, if you could just put in a couple of answers there. So from our list of 20, a few from the top. So thank you, Dr. Karthika. So malignancies, cardiovascular diseases. So even though our first case was of cancer, cancer is not the only thing. And so for our second case scenario, let us take someone with cardiovascular problems. Okay? So we have a medical student who visits his 75-year-old sister of his grandmother in the village. She's had an ischemic stroke 4 months ago, and she's been bedbound with grade 3 hemiparesis. She has multiple painful ulcers in the mouth, a smelly pressure sore, and she screams in pain when the student tries to see the range of mobility. So then the student asks his uncle, can we sort of take her to hospital? And uncle says, the hospital has said there is nothing more they can do. She has a stroke and she has a weak heart. And your mother has told you that this uncle is deep in debt after the patient's 3 ICU admissions. And even the money which he had saved for his daughter's engineering college studies is all gone. So that is the scenario that the students are facing. Now, if a middle class family, the granddaughter's education is affected because of the grandmother's illness and health care, what happens to people from poorer socioeconomic strata? It is estimated that 55 million people every year in our country are pushed below the poverty line because of healthcare related illness. Okay? And that affects generations. And here we're talking poverty line like $1 to $2 a day. There are others who may not go below the poverty line, but generations are affected. And such catastrophic healthcare expense is particularly common in situations where you don't have health insurance, you have people with limited resources, and you have growing options of healthcare technologies. If you're in a country where it's not there, then that won't push you into debt. No, that's not the answer, but so I would like you to think about what are grandaunt's domains of suffering, the ones we saw earlier: physical, emotional, social, and spiritual. Who can help her? How can we keep the costs low? Were so many ICU admissions necessary? But before we go on to grandaunt, I would like to show you a video of somebody who's much poorer than grandaunt. And when you see that video, you will also realize how healthcare expenses can become catastrophic because patients are hoping for a cure. They don't entirely understand. So as you look at the next video, take a paper and put a few notes. What is the patient hoping for? Why is he so desperately hoping for that? And unlike the uncle, instead of nothing more can be done, what does the doctor advise here? For this patient in this video, his name is Bhaskar. what are the physical, psychospiritual, and social concerns, and how did we keep costs low? So just give me a minute to share that video.
Good evening, sir. My name is Bhaskar. Doctor, sir, please operate to take this out. Only you can help me, doctor. You have to operate, doctor. Please, doctor.
Bhaskar, we'll definitely help you. But can you tell me what Dr. Joseph explained to you?
A nice doctor told me it was a cancer. I already knew that. But he said they cannot operate. But we know you can do something, sir. Doctors are like God. Anything is possible for you, sir. Please, sir.
Bhaskar, it is true, it is a cancer. And in many patients with this type of cancer, we do operate. I know it is very hard for both of you. You've come so far to the hospital, and here we tell you that we cannot operate. It can be very, very difficult. But I'd like to explain to you why it's different. Is that okay?
Yes, sir.
So this is the cancer, and these are blood vessels which go from the heart to different parts of the body to keep you alive. Now this blood vessel is a vessel that goes to the brain and the face, and the cancer is completely stuck to this blood vessel, and it is also involving other important parts of the neck. Are you with me?
Okay, sir.
So when we operate in a situation like this, we may not be able to take out all the cancer. And an operation where we leave behind some cancer actually can do more harm than good. And then when we operate in a situation where the blood vessel is so completely stuck, there could be a lot of bleeding. We could end up with paralysis of one half of the body, or there could also be a risk to life. And in this situation, I think these risks are not acceptable at all. And I would very strongly recommend that, at least for now, we do not consider surgery.
Sir, we don't mind any risk, sir, but I cannot live with this. The pain is so.
I understand that, Bhaskar. See, even if we are not going to help by doing surgery, we can help you through other forms of treatment. We can give you a type of treatment called radiation therapy, which will shrink the tumor, which will reduce the fluid coming out, and will definitely help your pain. And once we start, you will start feeling better. Dr. Joseph, what type of painkillers have you started him on?
He had a pain score of 8, sir. So I have started him on step 3 analgesics. I have given him tablet morphine 5 mg every 4 hours and PRN. And it can be titrated up.
Today, I want you to go and see our palliative care clinic. My colleagues there will help you with the pain and with the wound.
Doctor, sir, if operation not possible, then I have to just go, sir.
No, Bhaskar, don't say that, because I think we can really help you. Dr. Joseph will come with you and make sure you're taken care of.
Sir, I was working up some patients in the ward.
I know you're very busy, but I'm very concerned about Bhaskar. We don't know what could happen in this. Please go with him, stay with him, and make sure he's attended to. See what they do with him in the palliative care clinic and come back and tell me. So we can also start doing this in our clinic.
Thank you, sir. Thank you.
Even though we are not planning an operation, I would like you to come back and talk to us if you feel the need. Our OPD is tomorrow, and we will definitely make time to talk to you and your family members to make sure you're taken care of, your doubts are addressed, and that we work on this as a team. Don't ever feel left out and all alone, Bhaskar. We are with you in this.
Dr. Joseph from the Head and Neck Cancer Department. Dr. Kannan asked me to bring this patient to you. He has a squamous cell carcinoma of the hypopharynx with the right side at neck bone. It's 10 centimeter, hard, fixed and inoperable. His chest X-ray bloods and creatinine are normal, but there is a lot of outflowing discharge. Madam, Dr. Kannan asked me to stay until you finish saying.
Sure, Dr. Joseph. Please take a seat there. So you are Bhaskar. And how are you related to him?
I'm Rekha, his sister.
Whom do you stay with, Bhaskar?
Madam, he doesn't have children. After his wife died of cancer, he has been staying with my younger brother's family in our village. But after the tumor became big and started smelling, my brother's family said he cannot stay in their house. 2 days back, Bhaskar phoned me, and when I went to the village, he was sitting outside in the cold, crying with pain. My husband also doesn't let me bring him our house, but he said I can take him to hospital and stay till the operation is done, and then he can go back to his village.
Right. So I understand that is why the operation is so important to you, so that this tumor can be removed and Bhaskar can go back to your brother's place.
Yes, madam. I don't want to be a burden to anyone. My screams and cries are making it difficult for my brother's children also. And the pain, it is not helping, madam. Please, madam, you ask them to do operation. Even if I die, it doesn't matter.
Bhaskar, I'm really sorry that you've been through such agony. Okay? And to help you, we have better ways than this operation, which would harm you at this stage, actually. Okay? See, the tablets that you've been given, they may not be enough for pain as severe as you have. I think Dr. Joseph has written some new tablets for you today, and I'm sure that with that, your pain will become much, much better. Okay? Now, tell me about the smell. Since when has that been there?
No smell, madam. Everyone telling, no smell, no smell.
Madam, the smell has been there for 2 months.
Right. And have there been worms at any time?
Yes, madam. The tumor started producing worms. Actually, and that is when my sister-in-law said they could not keep Bhaskar in their home with the children. Otherwise, madam, they were looking after him very well until then. After that, she got scared. Producing all these worms, what else will happen to others in the family?
See, that can be very frightening for anyone. But if we work on this together, definitely we can prevent these worms from happening again. Okay. The first thing is to remember that the worms are not being produced by Bhaskar's body. They came only because flies laid eggs on that swelling. You know how sometimes we may see worms inside a mango?
Oh, it's like that?
Exactly. And what do you do if you want to prevent flies from sitting on food?
We cover it with the lid.
So that is why we must always keep the wound completely covered with a dressing.
But madam, I don't know how we will manage that. In the clinic in our village, once the cancer starts smelling, they told him not to come back. Today, here the sister did nice dressing. I can't bring him here every day. Even today, while we are coming to the hospital, the conductor shouted at us because of the smell. We have to get off and pay a lot of money to come by an auto.
I really appreciate the fact this trouble to help your brother, but we need to make it much easier for that dressing to be done regularly. We'll do 2-3 things. First, to reduce the smell, we'll give some simple tablets. Okay? And once that is done, dressings will be easier to do. In fact, most of our patients and relatives, they learn to do the dressings at home. It saves a lot of time and money and travel. Our nurse, she will teach you today. Bhaskar, do you want to ask me anything else?
Doctor, I am not afraid of it. Only thing I don't want is to be a burden to anybody else. Will this cancer spread to the family? I don't want it going to anybody else.
No, Bhaskar, the cancer will not spread to anyone who's staying with you or looking after you or eating with you. Okay? So, do you want to ask me anything, Dr. Joseph?
Madam, what will you do about this terrible smell?
It's actually quite simple. We know this is an anaerobic malodor. So first, we give a full course of oral metronidazole. But in this hypoxic necrotic tumor, the anaerobic necrosis is going to continue. So we will keep him on daily oral metronidazole. Otherwise, we used to find that the smell comes back, and smell brings flies, flies bring maggots. Patients can die really terrible, lonely deaths. You prevented a big tragedy by bringing this patient here yourself today?
Madam, actually, to be honest, I was reluctant to come with him. After I joined this head and neck cancer fellowship, when I see patients whom we can operate, those who are doing well on follow-up, I'm very happy. But when these kinds of patients come, but now I understood why they were so desperate to remove that slightly fungating tumor. Actually, when we were coming through the hospital, we were moving away from us. I was wondering why this lady had brought him. But now, when I heard her story about how much she struggled to help her brother, I really think she's a much greater person than me.
I'm really very touched by what you have said, Dr. Joseph, because very few of us have the humility to accept our limitations. And many of our patients are braver and wiser than us. I really think if you continue on the same track, learning from your patients, you'll become a wonderful head and neck cancer. Right. So, would you like to put some answers into the chat box? Now, it is a 1 hour session with the medical students. So after this video, they can go back to this original case scenario of someone they might see and apply these same questions to that. That's the case scenario again. And if it's a large group, I can ask them to think, pair, share. If it's a small group, they can have a discussion. What are the domains of suffering? Who can help? The family, the physiotherapist, the nurse. How can we do that there? Instead of those ICU admissions, would some physiotherapy and nursing have helped her more? Then we go back to the definition about palliative care being active, holistic, to improve the quality of life. And as we saw in our last video, patients, families, and even healthcare professionals struggle with these issues. And the basic palliative care skills makes it much easier and much more rewarding for all of us at this very important and precious phase in life. A little bit more about palliative care, that it involves a comprehensive assessment and management, physical, psychological, social, and spiritual distress. As we see in the case study, all of these things are happening. The aim is not to cause death, but to give support to help patients to live as fully as possible through communication, through clarity on what are the goals of care. Here, Bhaskar started with one goal, but we moved to another. It can be given along with disease-modifying therapies, like we talked about radiotherapy here, and also in a curative condition as well. Palliative care affirms life, wants to support quality of life, wants to make life meaningful, but it acknowledges that dying is a natural process. And less than 4% of those who need palliative care in India have access to it. There is no way the need can be met only by specialists. Just like basic life support, all medical professionals need to know the basic skills of palliative care. Even if we had thousands and thousands of specialists, who's there at the ground level on the spot when someone needs basic palliative life support? And that is why this curriculum is being integrated right into the MBBS curriculum, right from your first year, so that in your own ways, you can bridge the gap. Works with the family. We acknowledge that death is unavoidable. There is no one in this world who who will not have to leave it. But sometimes we think, oh, did the patient die because I made a mistake or my colleague made a mistake? Not every death is because somebody made a mistake. Not every death is a medical failure. And because of fears like that, we don't have to put patients inappropriately into ICUs, where the death of one generation is causing, in some ways, the social death of future generations. So let's just close with a couple of questions. Is this true or false? And we know from our presentation that all of them are false. We don't have to wait until active treatment is over. Pain relief is only one part of it, and it is not given only by palliative care doctors. It can be given by the family and by all of us. And I would like you to have a little bit of homework. District where you come from, where your grandparents and where your granduncles live, what palliative care services are available there. Okay? And these are two links that you can look at and try and identify what palliative care services are available there. Do they have morphine? How far will they have to go? And maybe someday you may be able to do something to add to that list.
Can we take up a few questions if there are any? Like, can we just spend 2-3 minutes? Is that okay, ma'am?
Yeah, of course.
If anyone have any questions, please unmute yourself, or you can type it in the chat also. Anyone would like to unmute and speak or type in the chat before we wind up today's session? Is everyone there? Sorry, we can't see your video, so just making sure you're all there. Yes, yes, sir. That's nice to know. Thank you so much for switching on your video so that we can see some faces than the icon.
Ma'am,
Yes, Dr. Karthika.
see, in the West, it's there are a lot of end of life care systems and palliative care systems which are state sponsored and even private, and which are regularly visited by patients. And they've got an excellent support system. But in our scenario, especially because of the enormous population and lack of funds, it is unimaginable to have, especially a state-sponsored system. But and the existing palliative care facilities also, I don't know if it's because of lack of funds or is it lack of volunteers. The quality of pardon me for saying this, but the quality of life that the patient, it's more like patients are being kept there by the family because they cannot afford to have time or money to spend on them. So at least in the distant future, do you see a change in the scenario? Because it's really sad, because people who have money, affluent families, can have good palliative care. Others are just neglected and they have a terrible end of life situation.
Thank you for raising those very valid points. Where are you based, Dr. Karthika? Sorry,
Right now, I'm in Puducherry, but I belong to Trivandrum.
Yeah. So it's very, very patchy. And in fact, sometimes even the wealthy get very poor palliative care because they are the ones who are likely to die on a ventilator.
Yes.
So that kind of suffering they face. I think how fast things change will depend on how much, what, and how well. You know, like for me, I was kind of overwhelmed by the resources a UK hospice needed to provide palliative care. But when I saw what Dr. Rajagopal and his team were doing in India at very low cost, morphine doesn't cost much, listening doesn't cost much, teaching the family to do dressings doesn't cost much. Finding good-hearted people in the community who will give the caregiver a respite, finding an NGO that will help support the children's education, those things don't cost much. But what it needs is someone to be the mobile igniter for that.
Some leadership.
Leadership, even to be the kind of Nidus. And there are a lot of good people. Once you start doing your little bit, others come. And you know that story of the walking by the beach and putting that little creature back into the water. So somebody says, what's the point in putting this one back into the water. There are thousands more, but it makes a difference to this one. And I'm sure when Dr. Rajagopal started in his OPD as a professor of anesthesia, trying to address pain, he may not have imagined this day when there is at least this much. So I think if we can do what we can do, if we can do it well, with a good heart, cost effectively, networking with others, then like a plant, it will grow. It will take time. And I would say that there is a need for it to be in the public health system. It has been in Kerala and in a few places, because that will reduce costs and improve care and make it more equitable.
Yeah, the equitable factor is what is staring.
Yes. And again, sometimes it is about partnerships. Like I know one organization, they're not into healthcare at all, but they're into business. So what they did is they built a charitable place for palliative care. They said, we can't run it, we can't manage it, but they gave it to a regional cancer center which had many patients who needed it. So it's like the blind and the lame. When they come together, much more could happen. So, but a beginning has to happen where we are. Yeah.
Thank you, ma'am. Thank you, Dr. Karthika, for the question. And I think this is another beginning of meeting you all here for a larger purpose. And through you, we will be reaching around hundreds of medical students in the coming years. So, yeah, this is definitely a great beginning.
And as someone mentioned before, as far as medical students are concerned, they are only bothered about getting marks for the exam. If questions come from palliative medicine, they will study palliative medicine. It's come to such a situation now. I mean, that's what at least we are seeing nowadays.
The thing is, it's kind of trying to target both. So out the 98 who might only study for the marks will still learn the WHO ladder and the steps of breaking bad news. The 1 or 2 who may do something more, you know, like someone was saying how they went and got time from community health for it to talk. You never know where they will run with it. They've got a long life ahead. Huh?
And again, it depends on the rung of the ladder you stand in your institution also.
Yeah.
When you are in one of the lower rungs, it's kind of difficult to convince the elders and the seniors to.
So sometimes if you can find a respected person in the higher rungs, can be your spokesperson, if you can. But if you can't, just begin with what you have. You know, and then someone sees that and you never know.
Gets inspired, hopefully.
Yeah.
All right. Thank you so much.
Thank you.
Thank you so much, both of you. And thank you so much, everyone else, for sitting for so long. We overshot time a little bit, but tomorrow onwards, I promise we'll stop by sharp 5 and we'll take the breaks adequately. Thank you so much, Dr. Reena, for coming today and sharing your knowledge with them. Thank you so much.
Thank you.
Before you all leave, I'll just quickly say what are the plans for the rest of the program. It will be slightly different from today's schedule because today is the beginning. Many of members are not really started doing palliative care. So we thought an introductory session was mandatory. So you might have already received an email or in the WhatsApp group. You are divided into small groups. You'll have 5 members in your group. So 5 to 6 participants in each group, and you are allotted to one mentor or a facilitator. Who will be an expert in palliative care. And you can see we have emailed all the subtopics. So tomorrow we'll be taking up these 2 topics. Today we heard about illness trajectory and serious health-related suffering. So we want to hear from you how effectively we can deliver these sessions to medical students. So you can come up with your own ideas. A small you can choose one subtopic. Each member can choose one subtopic. You can just prepare anything, like it can be how we are going to teach this and a few ideas. You can create 5 slides. You can come up with a video or some activity that you're planning to do to convey these sessions. Or we have already shared all the resources that we have on illness trajectory and SHS, including today's lecture. So if you want to use a recording of today's lecture, that is also fine. So please prepare for the subtopic, which one you want to choose, and prepare. And tomorrow we'll be having small groups. So the facilitator or the mentor will be there. We'll present the ideas in the small group and come up with a whole idea by the end of evening that how we are going to deliver these sessions to the medical students. And for example, today we have discussed illness trajectory. So you can see 6 subtopics. So suppose group 1, we have 5 members. One member can take one subtopic. The second member can take the third subtopic, or so on. I hope I am clear. I don't know whether I'm clear. So please, if you have any queries, you can always communicate with us through the WhatsApp group. So you may have to coordinate among yourself. Please make friends. Some of you are from the same institution, but there will be a mixed group also. So please communicate among yourself who is going to do which topic. Just come up with ideas or presentations or videos or activities, how we are going to teach illness trajectory as well as serious health-related suffering for second year medical students. Thank you so much. If there are any questions, so this is the group that we have divided. We have shared, yes, Dr. Annie, this is for tomorrow. We have shared the group details and the mentor for each day in your email. Please go through the emails. We have shared all the resource materials, which includes PowerPoints, trainer's guide, related articles, related videos, everything that you need under this topic. So please make use of it. You can either use those resources or you can make your own. You might be already teaching this topic, so please, you can use your own materials also. So see you tomorrow again at 2 o'clock. Tomorrow we won't overshoot the time. We'll stick on to the time. Thank you so much, everyone.